Good morning, America. Good afternoon, Europe, Africa, and good evening, Asia and Australasia. My name is Napapong Napang, the ISRT Vice President for Asia and Australasia. I will be the host for today's event. We are so honored to have the guests from the Danish Society. This is our first collaborative webinar between ISRT and the member society. We are so excited about it. And the topic today will be on MRI safety. And on this special occasion, I would like to invite our President, Donna Newman, to give some inauguration speech. Donna, please go ahead.
Hello, everyone, and welcome to this webinar on MRI safety. I'm very excited to have this co-hosted program. It only seems fitting to do this with the Danish Society. Denmark has been involved with the ISRT from the very beginning. They're one of our pioneers. They've actually helped us build our society. They've supported our society, and they've helped shape the ISRT to what you know it today. I'm so excited to share this platform with them. And I'm excited to hear from their president and hear a little bit about their society. So I'd like to turn this over to Charlotte to talk a little bit about their society and give a welcome.
Thank you, Donna. And tonight and today, we are honored to have the president of the Danish Council of Radiographers, Charlotte Gørngard Fogvert. And I would like Charlotte to give the opening speech here also. Thank you.
Thank you, Donna, and thank you, Napapong. It's an honor for us to be the first member society to collaborate with ISRT on these events. Thank you for that. I am, as you have been told already, the president of Danish Council of Radiographers. We have 2,500 members, and we are, as a society, solving usually tasks for trade unions, but we also do a lot of work within the profession. Regarding MRI safety, we are working on. There are still a way to go, even though we have been working on this task for several years now. We try to make awareness on the area in cooperation with our members. And I see that as a very important role for society to work together with the members on the profession issues. And for that, we need dedicated radiographers, and Anne-Dorthe Blankholm is one of those. And that is why it is an honor for us, that Anne-Dorthe Blankholm is presenting today. Thank you, Anne-Dorthe, and thank you, ISRT, for this opportunity. Enjoy the session.
Thank you, Charlotte. Thank you so much. And I would like to take this opportunity to introduce our speaker today. And our speaker today for the topic of MRI safety is Anne-Dorthe Blankholm, and a graduate with mathematical physical baccalaureate degree from Salzburg Gymnasium in Denmark. And she did her radiographer from School of Radiography in Denmark also. She finished her Master's of Science in Magnetic Resonance Imaging from Lancaster University in United Kingdom. And she finished her PhD in Medicine from Aarhus University, Faculty of Health Science in Denmark. Currently, she is a researcher, also clinical specialist, radiographer at Department of Radiology, Aarhus University Hospital. And she is president-elect for 2021 to 2022 for the Society of MR Radiographers and Technologists, SMRT. And that is a section of the International Society of Magnetic Resonance in Medicine, ISMRM. So I would like to take this opportunity to welcome you and to give a talk. And thank you, Anne.
Charlotte, it's truly an honor to be here, and I thank the ISRT and the Danish Society for inviting me. I'm really honored, and I would like to say that, or to emphasize that the opinions that I give today is entirely my own opinions and not the opinion of the SMRT or the ISMRM. So thank you.
Thank you, and please go ahead with the presentation.
My name is Dorte Blankholm. I'm a radiographer and a PhD from Aarhus University Hospital in Denmark, where I work as a researcher and a clinical specialist. First of all, I would like to thank the ISRT for inviting me to give this lecture, and the lecture is entitled MR Safety Update from a Radiographer's Perspective. The concept is a brush up on MR safety. It's about the recent incidents and publications on MR safety and something about the concerns and impact related to MR safety. And it's also about what we can do as radiographers and radiographer leaders to improve MR safety. So, as you all know, we have 3 types of fields. We have the static or main magnetic field, the gradient fields, and the radio frequency fields. The static magnetic field is always on, and that's responsible for the projectile effect or the attraction. It's also responsible for rotation and torque or translational forces and the lens forces. The gradient fields are time varying, and they are accountable for the acoustic noise. And this is why I use this image. As you can see, babies or infants, here we have some special challenges where we may have to use customized earplugs and customized hearing protection. That of course has to be MR safe. And the gradient fields are also responsible for peripheral nerve stimulation. The RF fields is responsible for heating. And to this is associated SAR, the specific absorption rate, B1 plus RMS, and the SED, specific energy joules. And when you look at this image, one of the most important things is of course to isolate wires and coils from the patient's skin. And I would like you to put your attention to this poster that's taken directly from the ISMRM and SMRT homepage. And here are some really good things about how to prevent burns. And another safety risk is of course a quench, which can simply happen by itself, but we can also cause a quench by pushing the quench buttons. They can look very different, as you can see in this image, and also people don't agree on what symbol to use for the strong magnetic field, so you should always know which button are the quench button. So what is a quench? Most of our MR scanners are superconducting magnets, and those are cooled with liquid cryogens. That can be helium and or nitrogen. They are 269 minus degrees Celsius or 4 degrees Kelvin. And a quench happens if the temperature in the superconducting wire or the area around it increases. That causes the cryogens to boil off, so they change the state from liquid state to gas, and that makes them expand very quickly. Helium can expand up to 750 times, and helium gas also displaces oxygen, and that is part of the reason why we have to evacuate the room immediately when a quench happens. And something about the safety zones. Those are defined by the American College of Radiology. And of course, MR departments can be very differently organized, and we know that sometimes MR scanners are placed in old buildings with limited space. And if you look at this drawing, you can see that zone 4 is the room where you have your magnet, and the zone 3 is your control room, and then we have zone 2 as both the reception and the patient dressing and holding room. But in some places you may have a preparation room which have a door into the magnet room, and that of course changes the way your zones are organized. And you can also occasionally have departments where you enter directly from zone 1 to zone 4, and that's of course very high risk. So think about this when you are making new buildings or when you're planning to reorganize older buildings by putting in new scanners. MR systems are increasingly being installed in environments outside of conventional radiology and diagnostic departments. For instance, MR-guided radiation therapy scanners, PET MRs, and intraoperative MR scanners. And this is associated with challenges both in terms of securing the physical environment, because the safety zones will differ, and also education of new groups of personnel and ensuring screening procedures. When we move on to labeling, we sort of have two types. We have the labeling for equipment that may be brought into zone 4, and then we have the labeling of implants. But as you can see here, the symbols are what we're going to use in the future. Those are MR safe, MR conditional, and MR unsafe. And MR safe is easy because MR safe is non-metallic, non-conducting objects that can be brought into the scanner room, whereas MR unsafe should never go near the magnetic field. And then we have the MR conditional labeling that for implants, with this labeling they can be scanned only on specific conditions, but also we can have equipment that are marked MR conditional. And when you look at this image, it's all equipment that where there's a risk it might be brought into zone 4, and I encourage you to use these labels so that you mark everything where you think there's a risk that it may ever get close to an MR scanner. And this is kind of a scary local example where you see we have a lot of equipment very near to the scanner room and no labeling whatsoever. So I really encourage you to go ahead and use these labels. So when we talk about implants, we divide them into two groups. We have the active implants, which is powered by electronic components, and we have the passive implants that doesn't have powered electronic components. And again, I would like to put your attention to this poster. That's also an SMRT poster with some really good advice regarding active implanted biomedical devices. Labeling of MR conditional implants. Here it is such that all medical implants have to be tested by their manufacturers for MR safety and labeled according to the standardized terminology. And that's the ASTM F2503-13. Standardized practice for making medical devices and other items for safety in magnetic resonance, the ASTM. So, MR conditional. It may have many conditions. It can have conditions with regards to the static magnetic field, the switched magnetic field, gradient field, and also the radio frequency field. There may also be additional conditions, including the specific configuration of the item that may be required. And condition of safe use should be directly identified in the labeling. And the MR safety information should include the field strength of the static magnetic field in Teslas, the maximum spatial gradient field in Gauss per centimeters or Tesla per meters, and the maximum MR system reported whole body average SAR. And any additional instructions or information is essential to safe use in the MR environment that can be described briefly. Under the described scan conditions, the device is expected to provide a maximum temperature rise of less than a specific given values in centigrades after 15 minutes of continuous scanning. And we can also see artifacts, the extent of artifacts being described sometimes. When it comes to screening, of course we have to screen everybody, patients and volunteers, personnel whether they are non-MR or MR personnel, and simply everybody who may enter Zone 4. So everybody must be screened, and of course, in my opinion, we should have a screening form that's very good, and of course you can customize it. I know many people does that, but it's really important that we don't leave anything important out of these forms. So personnel, patients, volunteers and relatives should be screened. Patients and volunteers, people who are going into the scanner, should be dressed in hospital clothing, because then we make sure that they are not having anything in their pockets. And also fabrics that may look like cotton can actually contain metallic fibers, and this image is simply an image of such a fabric that caused burn on a patient. And also one of my colleagues from the UK, Barbara Nugent, she suggested pocketless uniforms for personnel, which I think is a great idea, because then you won't occasionally or by accident have something in your pockets. And of course, when we're talking about screening, especially patients, there can be challenges. We have to find the conditions for an eventual implant before the patient arrives to the MR scan. And that means we have to get the information from the patient record. We may also have to go to an MR safety database to look implants up. And when we cannot find the exact information we want in such a database, we have to contact the manufacturer. We can go to their homepage or contact them by email and phone. And of course that's very time consuming, so it should be done before the patient arrives, saying that I know that's of course not always the case. So when we talk about screening challenges, we often discuss what documentation is sufficient. Is it okay to go ahead and scan when the medical doctor says, it's okay, go ahead and scan, just scan, there's no risk? And it's absolutely not okay, because you don't know if the surgeon or the cardiologist or whoever actually knows enough about MR safety. So we always have to go to the patient record, and we may have to look into a safety database or contact the manufacturer also here. And also very much important, if we're going to scan off-label, get written documentation from the radiologist, and any documentation that you get, for instance from the patient record or from a surgeon, always get the documentation in writing, just to make sure that you can avoid lawsuits. And what knowledge is required? You have of course to know the information about your scanner. You have to know the main field strength and the maximum spatial gradient, and also the time varying gradient, and the RF and the SAR limits. So let's just use a short time on SAR and B1 plus RMS. SAR and B1 plus RMS are two radio frequency exposure metrics used in magnetic resonance. SAR is the specific absorption rate, and the RF power transmitted in watts into the patient divided by the patient's body weight gives us the watts per kilo. And we have some allowable SAR limits. The normal operating mode is 2 watts per kilo, and the first level controlled mode is 4 watts per kilo. These limits are for the inbuilt body coil, and different limits apply for dedicated transmit head or local transmit coils. And I'd like to show you this scheme because normally we go for normal or first level controlled mode, but actually there's also something called the second level controlled mode. And I would say you should never go to use that on a human being, because here you can see there's actually no limit. You can go above the 4 watts per kilo. You can also see that there are different limits for local SAR than for whole body SAR. So B1 plus RMS is a measure of a time-weighted average RF magnetic field exposure calculated over 10 seconds intervals and measured in microteslas, and independent of patient characteristics, which is actually opposite to the SAR models, where the different vendors may use different SAR models. So that's one of the reasons why B1 plus RMS is used. The B1 plus RMS depends upon the flip angle, pulse type, number of echoes, slices and TR, and B1 plus RMS is useful in determining compliance with implant scanning conditions. So the FCD is simply the specific energy dose, or the RF energy absorbed per kilo body weight, and the SED is the SAR multiplied by scan time. The total absorbed energy in kilojoules is the SED times patient weight. So the SED really tells you something about how much heat the patient will feel. So setting up the MR scan when you have a MR conditional implant. Here what's really important is clearly specified conditions. And also the common limits we'll see described is mainly on field strength, it's on SAR and gradient strength. And it of course can be very challenging, but today the vendors are producing tools that can help us perform safe scanning when we scan patients with conditional implants. And here you can see some examples. You can simply put in the values that you find in the documentation of an implant, and the scanner will do the job for you so that you don't exceed any of the limits. One of our tasks as radiographers and technologists is to be able to reduce the SAR, SED and B1 plus RMS. And that's all about RF exposure management and how to support patient comfort. And it's also about knowing which patient groups are at risk of getting overheated. So how do we reduce SAR? On some scanners, we may even be capable of choosing low SAR mode. And that's a really great idea, because then some of the job's already done for you. The scanner then may change several parameters, but without impairing the image quality too much. You can of course increase the TR and reduce RF. That can be done, for instance, by reducing the turbo factor or echo train length and the number of echoes in multiple echo sequences. You can also use parallel imaging where appropriate, and you can decrease flip angles and of course also the refocusing flip angles, reduce number of slices, remove set bands or suppression bands, and use gradient echo sequences instead of fast spin echo or turbo spin echo sequences. And of course keep the room temperature low and also control the humidity. Dress the patient in light clothing and make sure that the ventilation fan is on, and you can of course interleave high and low SAR sequences. And of course these changes can impair image quality, And again, not all options are available on every MR system. And I would advise you, if you have made a really great sequence with low SAR, then store it so you have it and you don't have to use the time for creating it again when the next patients come in where low SAR is required. Coming back to the patients with reduced thermoregulatory capacity, and here we have a long list, and those can be patients with cardiac impairment, hypertension, diabetes, older patients, and patients with obesity, patients with a fever, infants, pregnant patients, and patients with impaired ability to perspire, and also patients in drug regimes that may affect the thermoregulatory capacity, such as diuretics, tranquilizers, and vasodilators, patients in a cast, and patients unable to sense or communicate heat sensations, such as patients in anesthesia, sedated, unconscious, and confused patients. And patients with implanted devices, of course, as we talked about, we have to apply to the conditions, and patients with extensive tattoos. Then we move on to talking about some incidents, and I call it recent incidents, but the first one that I'll mention is definitely not recent, but it is the incident that made the public aware that MR may have a risk. It was back in 2001 where a 6-year-old boy, Columbrini he was called, was killed by an oxygen tank. And we should think that we were getting better at this, but it seems that severe incidents and accidents keep on happening. In 2018 in India, a man died by asphyxiation after an oxygen tank was pulled into the scanner and the man was stuck to the scanner and stopped breathing. And last year, in 2019 in Sweden, a radiographer got stuck to the scanner wearing a weight vest, which is used for exercise. He got stuck to the scanner, he was unconscious, and he suffered serious injuries. It was at a private facility and he was working alone. This leads on to talking about reporting of incidents, and incidents continue to happen despite that we know the majority of incidents are preventable. Several databases for reporting incidents at hospital level and at national level exist in many countries. For example, in the US, the FDA has the MORT database. In the UK, they have the MHRA database, and we also have a database in Denmark. And if you go use this link to the ISMRM homepage, there are actually links to several databases for reporting. It's a common perception amongst MR personnel that we have only seen the tip of the iceberg when it comes to reported MR-related incidents. So therefore, I encourage you to remember to report all incidents and near misses, because this is the only way that we can document that these incidents and accidents actually do happen, and it's also the only way for us to learn from other people's faults and mistakes. And then I'll talk a bit about some of the recent publications about MR safety. I know that loads of publications are coming in about COVID-19 and the coronavirus, but it'll simply take up too much time to have it in this presentation, but you can find a few of those in the reference list. So talking about some of the recent publications, we did a Danish study where we looked into the national database. We looked at data from 2015 to 2017, and we also used a questionnaire that was national. We had 208 responders. The results of the questionnaire showed that 34% of the responders had been involved in an MR-related incident within the past year. And 25% had at some time in their career been involved in an unreported MR-related incident. And when we asked that question about the unreported incident, actually 28% answered, I don't know. And I think that's a bit problematic because it might suggest that they don't know what an MR-related incident is. And when asked why they didn't report the incident, 85% answered that it was because of lack of time. And of course we do have a busy working day, but reporting we must have time for. And here I show you some of the results from this study. These are MR-related accidents and near accidents results from the national survey, where we have the dark gray bar indicating if they has been involved in an MR safety related accident, and the light gray bar if they had been involved in an MR safety related near accident. And you can see that we actually have a number of projectile effects or attraction accidents, and also a number of burns and hearing damage. And when we move on to looking at the results from the database, these are results from 2015 to 17, and here we had to take the mean of all 3 years to make sure that we protect patient data. And you can see that here we have only 1 hearing damage and we have only 3 burns, whereas we actually still have a lot of, we have 18 projectile effects. And I mean, these low numbers of burns, for instance, may indicate that not all incidents or accidents are actually reported to the database. So again, I encourage you to report all incidents and near misses. And now we move on to another publication. This is a Swedish publication that's also based on a national survey on MR safety, where MR data are compared to CT. And this shows that safety incidents resulting in human injury and material damage and close calls in clinical environments do occur. And the risk level was high. The results indicated that MR personnel tend to have a false sense of security, and a high proportion of staff members were sure that they would have been aware if any accident occurring in their own department, while in reality it showed that incidents did occur without their knowledge. So they concluded that there's a false sense of security existing for MR. And also researchers from the FDA culled data from 2008 to 2017, and it showed that the majority of these events have known causes and therefore they are preventable, and they had more than 1,500 adverse events reports. The reports are from MRI, PET MRI and nuclear MR spectroscopy systems, coils and other components and accessories. As you can see in this table, they actually have the majority of the incidents, namely 59% were thermal incidents and 9% were projectile and 6% were acoustic. And here you see that the percentage of thermal burns are far higher than in the Danish study that we looked at, and it can be because we have different ways of doing things. It may also be because of how big the patients are, but at least it has something to do with preventing burns and knowing how to do it. There are also some recommendations for safety education that I would like to put your attention to. This is the Calamante publication here on MR system operator recommended minimum requirements for performing MR in human subjects in a research setting. And I think that's a very good publication, and also some of it of course applies to a clinical setting. And there are also the recommended responsibility for management of MR safety where the MR safety officer, MR safety expert, and MR safety medical director is defined. And then maybe the most important of the recent publications is the new ACR manual on MR safety that just came out here in 2020. And it's an update of the former ACR guidance document on MR safe practices from 2013. It has some main revisions on expanding staffing guidance, which is very important. It also has a full stop and final check, an update on contrast agents, and something about the typical environment, and difference to the Heart Rhythm Society on guidance regarding performing MR examinations in patients with non-MR conditional cardiac devices. So looking into the revisions with regard to expanding staffing guidance, it states that there will be a minimum of 2 MR technologists or 1 MR technologist and 1 other individual with the designation of MR personnel in the immediate zone 2 through 4 MR environment whenever patients are in the environment. And during this time, the 2 MR personnel must be able to directly communicate within earshot of each other at all times. It also states that in all other ways, the ACR MR Safety Committee supports the Veteran Health Administration Responsibilities Directive for the Medical Facility Director of 2018, which states that ensuring that when routinely scheduled patients or research subjects are present in Zone 2 through 4, there will be a minimum number of MR personnel in Zones 3 through 4 to assure safe operation and adequate access control. The minimum number of MR personnel is calculated as follows. For a facility that functions with 1 MR machine per Zone 3 and 4, there will be a minimum of 2 MR personnel in Zone 3 through 4, and at least one of these personnel will be designated a Level 2 MR personnel. And note that temporary exception is made when MR personnel are interviewing the patient or research subject or retrieving the patient or research subject from the waiting and changing areas. And of course, these changes with regards to staffing will have impact in some MR facilities. There's also the full stop and final check. And it says that a full stop and final check performed by the MRI technologist is recommended to confirm the satisfactory completion of MR safety screening for the patient, support equipment and personnel immediately prior to crossing the Zone 3 to 4. The purpose of this final check is to confirm the patient's identification, ensure that all screening has been appropriately performed, and ensure that there has been no change in patient and or equipment status while in Zone 3. There are also the formal MR safety roles. Here it says that it is understood that the MRMD will have the necessary education and expertise in MR safety to qualify as Level 2 MR personnel. The MRMD, MRSOs and MRSEs, as well as all MR personnel, should undergo MR safety specific education on an annual basis. And I think this is really great because this includes all of us, the radiologists, the radiographers and the physicists. And we may ask ourselves, do we all fulfill this? Will all of us have MR education, MR safety education on an annual basis? I think this is a take-home message that we have to emphasize that it goes for all of us. And then there's some concerns and the impact that we can have. Remember, as radiographers and technologists, we have a crucial role of ensuring the safety of the patients and involved staff. We should take the lead when it comes to performing safe examinations and maintaining a safe MR environment, in order to protect patients, staff and other involved persons. The MR radiologist, MR director or MRMD is the legal responsible person for the safety on the department level, but they are often not present in daily practice when the MR scanning is performed. So therefore, we have to take the lead in the MR environment. Of course, there's some requirements. It requires that we are aware of the possible hazards and having your procedures clearly described. Also, education is needed for radiographers, technologists, radiologists and physicists. The MRSO, MRMD and MRSE education. And I would like to emphasize that even though there's a lot of discussion about the captain of the ship doctrine, and some says that it is the radiologist who's the captain of the ship, and the fact is that when the radiologist is not there in daily practice, they're only captain of the ship for some of the MR examination, and therefore I would like to emphasize that teamwork between the radiographer, technologist, radiologist and physicist is essential for ensuring MR safety. So how do we improve MR safety? We should take the lead as radiographers and technologists and leaders and ensure local policies and guidelines are up to date and are known by all personnel. And ensure that your personnel have proper and sufficient MR safety education and that it's up to date. Ensure that the responsible radiologist, radiographer and technologist and physicist and all MR personnel undergoes MR safety specific education on an annual basis. And document it. Keep files to document it. Look at your MR environment and ensure that unauthorized personnel, patients and other persons are barred for access to the MR environment. And make sure that labeling is present and used correctly. When it comes to the question of implants, MR conditionals or non-labeled, and whether or not it's safe to scan, it is the radiologist's responsibility in the end. But this is exactly where teamwork is needed. The radiologist, radiographer and technologist, and sometimes the physicist is needed. The risk versus benefit of the MR examination must be evaluated, and again, it is the radiologist's responsibility in the end. But as radiographers and technologists, we should never act against better knowledge. But remember that it's easy to say no, but it takes courage and knowledge to say yes. And also saying no to a scan has consequences. It may be an undiagnosed patient who have to undergo more invasive studies. But always remember to document in writing if you're going to scan off-label or if you think you're scanning something that's really dangerous for the patient and you have to go ahead and scan. There's a lot of very good educational material, publications and other MR safety resources on the internet. And I highly recommend the Society of MR Radiographers and Technologists, the SMRT, which is a section of the ISMRM. The SMRT is the leading non-profit organization that provides an international forum for education, information and research in magnetic resonance for radiographers and technologists throughout the world. And I've already shown you some of the posters from the SMRT, so I encourage you to go and have a look at the homepage. On the SMRT homepage, lots of resources are available for free, but I encourage you to become a member of the SMRT, that I believe has some of the best MR education in the world. And finally, there's a few references you can take a look at if you like. And by that, I would like to thank again the ISRRT for letting me do this presentation, and thank you for your attention.
Thank you, Anne, for your very, very comprehensive talk. And it's very well structured. And I got some questions from the audience. Well, the audience now, you can still type on your question that you may have. It's going to be, if you watch from the Facebook Live, it's going to be either on your right-hand side or it's going to be underneath the screen. And for colleagues that watching via the Zoom, if you have any questions, you can ask Anne right now. Just try to speak. Any question from the Zoom audience first? All right, I got some questions from the Facebook Live. Actually, the first question is from Donna. The question is, who is responsible for contacting the implant manufacturer for the implant information? Is it radiographer or is it radiologist?
Thank you. Actually, I don't think that's printed anywhere who's responsible for that. I think it's very dependent on where you're located in the world and in what kind of department you are. For us in Denmark, it's like we actually wanted from the referring physician to say if the patient has implanted anything, and we want them to tell us what it is exactly. But often we don't get that information. And then when the patient comes into the MR department, it turns out that it's actually the radiographer who's sitting there and finding the information. That's what very often happens. And if you have the time, you're the one going to call maybe the institution where the patient had surgery years ago to get the information if it's not in an electronic record. And it can be very cumbersome, and I can only speak for myself, and fortunately that was in research, but I used, for one of the implants, I used about a week to get the message back from the company saying what were the conditions. And in other instances, you can simply go to the company's home page and see exactly what the MR conditions are. So it's very diverse.
All right. Yeah, that's quite tricky, because the point is, what if you don't know what the implant is? So do you scan or you wait?
That also depends on what kind of implant we're talking about. And I would always, if I have any doubt, I would always contact my radiologist, because it's the radiologist's responsibility in the end. Saying that, knowing that sometimes I may have a better MR safety education than my radiologist, it's the radiologist's responsibility. But of course, I mean, there are implants where you can go ahead and scan sometimes for some kind of prosthesis or what do you call it, other implants if you've had a fracture or something like that. But if you have any doubts whatsoever, I would always go and try to find out what the patient has, and I'll discuss it with my radiologist. And if there's a physicist available in the department, in some instances there might be a physicist, or you might have a physicist that you can simply call and help you guide with technical conditions. But I mean, it's a radiologist's responsibility in the end to say whether you're going to scan off-label. We call it off-label if you don't know what exactly the implant is.
All right. Thank you, Anne. I got another question from Chandra. I think she's from Australia. She would like to know if you have available the questionnaire that the participant completed on the MRI incident. That's what she asked. Maybe she asked if you have something to share.
Yeah, but unfortunately that's in Danish, so. But yes, of course, we can share that information. Absolutely.
All right, thank you. And another question is actually from Donna again. Do you know of any country that adopted the DACR guideline that you need to have 2 MR personnel during the scan?
Well, I think we should all adapt to that, and it's very diverse what people are doing, but the ISMRM, which is the National Society for MR and therefore also for MR safety, they actually say that that's the guideline we should follow. So there are discussions going on now, of course, about the new things in the regulation. And also sort of connected to this is the fact that in many countries we lack guidelines for MR safety. Such as in my own country, in Denmark, we are trying to get the politicians to grab the initiative to make such a guideline. And the only country that I'm aware that has such a guideline is actually Italy. And I think Charlotte wants to comment on that.
Oh, okay. Oh, another question is from myself. I'm doing quite a bit on the, yes?
Charlotte had something to add to it.
Oh, sorry. Charlotte, please go ahead.
Thank you. Yes, it was about the implant database. We are working together with Anna Dorte and several other MRI radiographers in Denmark to have an implant database. But the issue right now is that nobody thinks that they are responsible for such a database. The authorities throw us from one authority to another, but we think it's important to have an implant database, and such an database could be on a international level, as I see it, because what we know from the radiographers in the MRI environments, working in the MRI environments, they use a lot of time to research what is this for an implant, where did it come from, what can we do with it, and we could scan a lot of patients if we had a database where we could simply put in the batch number or something and then receive the stuff about the implant. So we are working on that.
All right. Well, thank you, Charlotte, for your information. And let me have another question. I'm currently work quite a bit with the Joint Commission and the Joint Commission International JCI, which is very popular in Asia Pacific. And one of the new requirements, which will be effective in January 2021, because it's delayed from the COVID, is about MRI safety and adopt the zoning system from the American College of Radiology. I just wonder what is going on in Europe or in a part of the world that you know of.
Actually, I must say I haven't seen anything new in that regard from Europe, but I think that this issue is becoming more and more important because, as I said in the lecture, we are seeing more and more MR machines coming into, for instance, therapy departments or nuclear medicine departments, and they're not coming into new buildings. They're sometimes coming into older buildings, so therefore there are high risk, not only because people are coming in maybe directly from zone 1 to zone 4, but also because it's placed in a new environment where people are not used to thinking about MR safety. And you might have a CT or a PET CT just next door where that kind of safety is not an issue at all. So there are huge challenges. And I think now about the zoning, but also about the staffing, it's really important because today there are MR departments where only one radiographer or technologist are located while scanning. And if you take, for instance, the incident that we saw in Sweden earlier this year, the radiographer was working alone, and actually the people, the security guards that were the only one there didn't know anything about MR safety. And as far as I know, when they released the radiographer from the scanner because he was stuck at the scanner, they found a knife and released him with that. And it's just luckily that, if that's correct, that the knife was not magnetic, because then it might have ended up in a completely different way.
All right, that's interesting. I have one question from the audience from Loma. It may be repetitive, but I will ask you anyway. She asked about regarding the implants, just like PPM, ICD, CRTD. during MRI, who's responsible for the safety of the patient? And she asked if do you have the protocol for that?
Yeah, I think that there are different protocols, and we're scanning that in our department. And I can, of course, only talk about what we are doing. And we're actually having, when patients with those active implants, we're having normally a cardiologist or an anesthesiologist. And if it becomes very much routine, it might be sufficient to have a nurse there, and then the patient goes to the cardiology department to have their pacemaker or wherever it is adjusted after the scanning. But it's not us as radiographers who are taking the responsibility. It never is. It's always the department of cardiology, for instance.
Oh, all right.
But
Just
yes,
yes, go ahead.
it depends on where in the world you're located, I'm afraid.
I think so. For the audience from the Zoom meeting, do you have any questions before we go ahead and?
Napa, there's two questions in the chat
Okay.
that are there to really good questions. I think we should have Anne address those. I think they look like very interesting questions. Are you
All
able to
right.
see it?
No, I tried to. I kind of.
Oh, can I ask it for you?
Yes, please. Yes, please.
Okay. One of the questions that was asked from the chat box, I think, is a great question. And I think this is probably happens quite often. Does anybody have experience when you have shared working areas, MRI and CT, scanning control areas? How do you manage sharing this area? I don't know if this happens in Denmark or not, but what would be a good safety measure for this type of question?
It definitely happens, and it is a challenge. And I've seen it in more than one place, because they might have a diverse personal for CT and personal for MR. So they actually end up setting up some kind of separation in the room to make people remember that you have to stay in the area where you're going. And I know that may not always be possible, but that's our experience where I work at for instance, the therapy department, the radiation therapy. They have a joint operating room, and they find that it's actually quite dangerous. So that's why they put a separation in the room. But it is a challenge, definitely. And I think that when you do that, you may, as personal, I think you should act like you were in MRI. I mean, having no metal in your pockets or no metal on you whatsoever, because if an incident happens and you have to hurry into the MRI scanner, you don't always think about emptying your pockets and getting everything off. So it is definitely a challenge, but it happens in our country too.
All right. Donna, you have the second question.
Yeah, the other question that was asked, which I think is great too, a technologist has asked, let's say that the implant manufacturer leveled certain implants as MR safe, and then you conduct a test and you found that it is MR conditional. You go on with the exam. That would be a dilemma for a radiographer. What would be the right answer for that in your country if they found something to be conditional that was labeled safe?
Yes, that's actually a good question. I think that depends on the way that you think, all right, because you should never have anything labeled MR safe when it is MR conditional. Because MR safe is something that doesn't contain any metal or any conducting material whatsoever. So if that happened, I would definitely contact the company and ask them, what is this? I've never come over that incident, I must say. It may, of course, it may happen, but then the company is not fulfilling their requirements for labeling.
Oh, okay.
Do you stop and go to the radiologist to hopefully back you? I could understand that a referring physician would want their tests done, but I would hope a radiologist would back us and say it's not safe.
I would definitely go to the radiologist and say, well, this is how things are. What is your thoughts about that? And I would, of course, tell the radiologist what my thoughts would be in such a case.
Yeah.
But I would, well, of course, again, depending on what kind of implant it is and where it's located and what I'm going to scan and the field strength, and well, there are many things to consider in this regard. I think it's much easier to answer if you have a concrete case where you say, I find this implant, it's located here and there, and I'm going to scan this and that. Then it's much easier to answer because it actually depends on what implant it is and where it's located, and whether or not it's going to be in the coil that are transmitting the RF, such as the body coil, for instance.
Oh, thank you, Donna. I have another interesting question. Maybe no one asked yet. What is the policy in your place about pregnant patient undergoing MRI?
Actually, we do scan a lot of pregnant patients. We still have the conditions of saying that we normally don't scan in the first trimester. But then if you may need let's say CT, and you can do it with an MRI, it's better to do an MRI because we know that X-ray is dangerous for the fetus, whereas we don't know that for MRI. But we scan a lot of pregnant patients, and of course, we, where I'm located, we try to emphasize that we take down the SAR, and we try not to make the sequences too noisy and stuff like that, but we scan a lot of pregnant patients. And it was regarding patients because we also have people working in MRI while pregnant. There were years where we said that the MR techs or radiographers could not go close to the scanner, but that's different today because there has been many publications showing that there were no danger associated to it. But if you work with very high field strength, you may restrict it to being in the operating room and not entering the scanner, or have a 5 Gauss line or another line where you say that's how far the pregnant worker should go.
All right.
But,
Thank you very yes,
but a pregnant worker should not stay in the scanner room while scanning.
all right. Well, thank you. And I have another question from Ansumana Dabo. The question is, in an event that there is no contact between you and the company, how will you check the patient's safety when the scanning tools aren't available?
Yes, then I can't check it, of course. And then I'll have to go to my radiologist. And because it's the radiologist who decides whether or not to go ahead and scan.
All right.
Okay. It is in well, saying legally, it's the radiologist's responsibility.
Mm-hmm.
That's why I have to go and make sure that what I'm doing is okay with the radiologist.
Yeah, but
the question is flowing. Yes, Donna?
There's another question that came in the chat box, kind of a statement question. I think it would be really wonderful to hear Anne's thoughts on this. How about MRI during pregnancy with use of gadolinium? Use or not use?
I wouldn't use the gadolinium on a pregnant patient. That's a simple no, because that's what in the guidelines of the gadolinium contrast agents, that it may be dangerous for the fetus. So we don't use gadolinium at all. And I don't know about the local guidelines, but I know that in the European guidelines, the ESUR guidelines, it says not to use gadolinium on pregnant patients.
All right. Thank you. I got another question coming in from Elizabeth Balogan. What her question is, does the RF strength also determine the implant? Most MRI used in this part of the world are usually between 0.2 to 1.5 Tesla, and she's from Africa.
Can I have the first part of the question again?
Does the radio frequency strength also determine the implant? Probably the relationship between the radio frequency and the implant.
Yes, the radio frequency really sort of decides how much heat you dispose into the patient. So yes, it's always an issue, and it's always also an issue on the 1.5 Tesla, because the size of an implant is an issue in that regard. If you have the size is related to the resonance frequency of your magnet, and that's dependent, of course, on the magnetic field. So it's always an issue. And it is such that an implant that may be MR conditional on 0.5 may be MR unsafe on 3 Tesla and vice versa, because it's the length of the implants and how that's related to the resonance frequency that can be an issue as well.
We have a flow of questions coming in. Donna, you have anything on your side?
Yeah, there is another question here from our Zoom audience, and it is any safety issue for first trimester pregnant women? If yes, is there any limitation of the duration of scan time?
Yes, I would say there always is. If you had to scan a first trimester pregnant women, you should definitely also restrict your scan time. But again, it's difficult to say, because if you have to do a certain scan, then I mean you have to do it, because what's the alternative for that patient? So if your radiologist asks you to do it, I would do it, but I would, of course, again, document it. And in terms of how long you're scanning, I would say, look at your SAR, look at the SED, have close contact with the patient, because pregnant women are also, I mean, concerned of what's going on. And I would keep the scan as short as possible. And I would try to interleave high and low SAR sequences, not to heat up too much. But actually, I think it's a discussion, because I don't think that maybe heat of the fetus is a big issue. It depends on what you're scanning. Again, if it is in the pelvis or if it's the head you're scanning, it's very different. But in terms of how long the scan should be limited to, I can't give you an exact number, I must say.
All right. Oh, very interesting point. Well, we have questions coming in. Maybe we have time for 1 or 2 more questions, right? Donna, you have anything else on the Zoom?
Nope. Go right ahead.
All right. I think I have one more question. Maybe it's repetitive, but I will ask anyway. From Mr. Kim Mung Tin from Myanmar. The patient has been implanted the aneurysm clipped. Nobody know what is the conditional, if it's conditional or not. For patient safety, shall we postpone the MR investigation? How's your opinion?
What was it again? The implant? It was
a aneurysm clip, and they don't know what it is.
Yes, I would definitely postpone it, because if you don't know what clip it is and you don't know how old it is, you don't know whether it's MR conditional or MR unsafe, or it's only MR safe if it's non-metallic. So I would definitely postpone the examination, because you don't know what's going to happen when you put the patient into the magnetic field.
Oh, what a great session we have today. And according to what you presented today, I'm sure we have a lot of things to learn from you, especially how to optimize the scanning protocol for patient safety and things like that. So in the future, we are looking forward to have your contribution again, Anne, and I really appreciate you coming here to give the presentation. And of course, the audience from both Zoom and the Facebook Live, you can always come back to watch. We will record it and make a video rerun on the ISRT website. Thanks again, Anne. And before we close the program, Charlotte, you have anything to say as the president of the Danish Society?
Yes, I would like to thank you, Anne. I do that a lot of time because you're always helping us. But I would like to highlight something that Anne said, and I think it's important for our profession all around the world. Anne said we have to take the lead when we are working on the MRI environment. And I agree on that. And I would end my little speak here by saying that we are the patient's ambassadors for safety in the MRI environment. And it's a big responsibility, but actually we are the only ones who can take that responsibility. Thank you.
Oh, thank you, Charlotte. And Donna, please have a say.
Yes, I can't thank Anne and Charlotte enough for coming on and planning this program with us and being our first member society to launch this platform. I'm just excited to have this available for people to rewatch. And it just goes to show that with hybrid imaging, we're going to have more and more radiographers working in non-traditional settings. And our key experts from around the world really do have best practices to share. And this is a great platform to allow that to happen. I know that the WHO's strategic plan this year is safety. And we know World Patient Safety Day is happening on September 17th. And so this week, it's just key to have this type of education from our members from around the world. And I thank the Danish Society for agreeing to do this with us. And I appreciate this opportunity to have our experts share best practices. So thank you again. I look forward to more programs like this. And please, if you have time on September 17th, join us for our webinar at the same time for World Patient Safety Day. And thank you again to all our audience that tuned in today. And for those who didn't have time to watch it, please watch the rerun. It will be available on our Facebook Live and on our ISRT website. Thank you.
Thank you, Donna. Thank you, Anne and Charlotte. Thank you very much for a wonderful webinar we have today. And for the audience, I wish you have a nice morning, nice afternoon, nice evening, and nice day. Goodbye.